Good morning, class. Please confirm that you're able to listen to me clearly and loud enough. Just a second, I'm unable to see the chat window. I may have to restart the meeting. So let me rejoin or just stop the share and then start the share again. Yeah, now it's visible. Okay, so this is section B, isn't it? Yeah, and the last thing that we talked about was delirium. Okay, so what part of delirium? Referring and admissions. Okay, so we have talked about the treatment, and now it's about when to refer the patients off and to admit the patients of delirium, right? First of all, when the evaluation for the patient did not reveal any underlying causes, any obvious things that you could alter, and therefore address the confusing state of the patient. So, if it's not giving any clues, the initial evaluation, in that case, you may refer it to a specialist. Right, and um, therefore, the presentation of the patient when it was as such that you are considering delirium and some other condition as well. So, you're keeping that option, which means the differential diagnosis that you would have created because of the presentation variation has something other than delirium in the list as well. And obviously, evaluation is not very clear. So, in that case as well, and overall, the concept is when you need specialized advice or specialized guidance, or you know, patient needs specialized help for diagnosis, then this is what it means. When differential will have anything other than delirium in it, then you need some special help for diagnosis. Right, so in that case, refer these patients to obviously these three varieties of specialties: neurologists, neuropsychologists, and geropsychiatrists or simple psychiatrists as well. Um, you know, because this could be a super specialty, let's say, a specialty within the specialty. So if there's a psychiatrist dealing specifically with elderlies, then yeah, it's even more better. And we basically simply have no clue at all about the patient's underlying causes and uh, coexisting conditions and medications and whatnot, so to evaluate and to work upon the patient. So for that reason you can admit the patient, right? And that obviously is in the case when you decide to do that extensive workup and observation is required. So in that case, admission. Next topic is immobility. Now you guys already may think that you know quite a lot about it. Yes, you do. But there's always some different angles to look at things, and some minute, easy, easily overlookable details that, as I've been saying, are crucial, you know, in case of these elderlies, in case of the geriatric age group. And if you overlook them just because, oh, that's very obvious, oh, that's very easy, oh, that, well, if you try to do that only on the patient, they won't be happy. Understandable. But the historical data has always been pointing at, which means the evidence states these are the most important things. And then some other aspects of immobility that may not be in your knowledge, probably. So, immobility means quite a few things. It means a person not being able to. So, what? Let's see what you may think about it, a few of you. 117, I'm unmuting you and let's take your opinion about what do you think immobility in elderly may mean. Roll number 117.
Yes, sir.
Okay. So the topic that we're going to start, the word is quite obvious, immobility. So can you share your opinion about what immobility in elderly may mean?
Uh,
Yes, speak up. Can you hear me?
uh, yes, sir. I can hear you, sir.
So what does immobility mean in
So,
terms of elderly?
so,
Yeah, I think your voice is breaking up. Let's pick another student. 141. 141. Can you hear me?
Hello.
Yeah.
Hello.
So,
Good morning, sir.
good morning. So, this immobility, could you shed some light on to the varieties of immobility?
So, immobility, person is unable to move or to be moved
That is it, but obviously in which context?
due to the diseases or some physical causes that
Okay, fine. Thank you. So, um, number one, think about a patient who is unable to move at all and they are immobile. Number one, maybe they're paralyzed. That's one category. Another one who can move but has difficulty in moving, right? Is not paralyzed, can move, has difficulty in moving, because of pain or disabling condition affecting one or a few of the limbs, maybe. That could be not just a paralysis, that could be fractures, that could be amputations, that could be anything at all. So, due to number of reasons, a patient can move but has a problem moving in it, and therefore, obviously, chooses not to move Also chance of dependency for each work weakness. Exactly, frailty syndrome as well, right? So number of causes. We'll talk about causes for immobility as well. The point is, it's not necessary that the patient is just unable to move. There could be a lot of other ways in which a patient is just not moving and is probably lying all the time, or chooses not to move much or cannot move much, right? So, and then out of that, remember in this immobility, uh, a person could be lying down, a person could be sitting, and a person cannot be standing, obviously, right? So, either sitting or lying down. And most of the problems of immobility arise and are related with number one, immobility itself, number two, lying down, right? Sitting up is a million times better than lying down. Now, sitting down obviously will also have its own, constantly sitting down with a straight back will also have its own drawbacks, because whether you're sitting up or you're lying down, your body still is suffering uh, from certain points where the pressure is being exerted the most, right? So in case of lying down, it's the heels of the feet, it's the hips, it's the sacral region, it's the back of the shoulders, isn't it? And when a patient is sitting down all the time, it's mostly uh, hips, buttocks, and the sacral region, but different aspects of sacral region, the tailbone area. And obviously, yeah, bed sores can develop in such patients, but it's a topic on its own separately, right? So, immobility associated with a lot of hospitalized patients. So,
नहीं.
if a patient is hospitalized and is in age group of geriatrics, um, very much chances that they can become immobile. Disability and mortality as well. Uh, Chances of death increase for a patient when they become immobile, and the chances of uh, disability to actually settle in related with the joints of the patients and limbs of the patients. Once they become immobile for extended period of time, they can become disabled as well in this age group, right? So once a patient is immobilized, chances of their hospitalization, that's why it's seen a lot in the hospitalized elderlies as well. And these two things increase significantly. And for any reason, if a patient has been advised a bed rest, right, especially when they are admitted in a hospital, is very strongly associated with their functional decline. That, I mean, if they're advised bed rest in this age group, which requires them to mostly be active, be, you know, um, more mobile, one has to be recommended to be immobile and have bed rest. Expectations should be that their function will decline, right? And therefore, we'll need to counter those possible, probable arising problems as well with the approaches that we mentioned. And 70 plus age group, this is a historical fact. 10% of 70 plus age patients suffer from immobility. That's does not seem too much, but imagine it this way: that 70% of UK population is more than 60 years of age. UK population is described as an old population. India and Pakistan, probably Bangladesh, Nepal, these countries' population is defined as to be a young population, because most of our population are less than 30 years of age. That's why we are called as young population. So in a country, for example, whose population is mostly more than 60, 70 years of age, 10% of them are, imagine what kind of a burden is it on society, on the health system, right? So it's an extremely important figure if you can, you know, understand it. I included an image here, you know, representing an elderly lying on the bed holding on to a bar, and that's just some image that I got from online, but it kind of entails dependability, right? Lack of freedom, and that further leads on to being more and more immobile. What are the varieties of hazards that the bed rest can lead on to cause in the elderlies? A variety of different. The problem with them is that they develop very quickly over days. Once developed, managing them and treating them and curing them takes longer period of time. It could be weeks to months. So they're quick to develop and slow to reverse or treat and cure. That's the problem with the hazards or complications and outcomes of immobility in elderly. And once something has developed which requires an ongoing care, it's a chronic problem, right? So it's not going to be that hazard of immobility itself. It's going to be quite a few other things along with it. It's going to be further dependability. It's going to be further decrease in daily life activity. It's going to be further decreasing the chances of socializing and reorientations. It's going to be further leading on to put the patient into a possible depressive state of mind, right? And then it's an ongoing. So everything matters in this age group. So another thing that happens very quickly, as we said, there's a lot of problems that start to rise from immobility, and these changes that happen, they happen very quickly, right? And then to reverse them, it may take a lot of time, or to treat them. So one of the things which develops very quickly, especially in this age group, but not only in this age group, that is um, what you call it, deconditioning. Yeah, cardiovascular deconditioning, simply referred to as deconditioning as well. Now, it's not just cardiovascular. Yes, that is a major part of it. Uh, Most of us would also be deconditioned. The ones we are young, right? Obviously, you are more young than I am. But in my age group, especially around this area, 30, 40 years of age, uh, you know, youngsters start to feel the burden of physical activity as well. And the more active they keep themselves and more fit in terms of BMIs they keep themselves, the better conditioned they are and can keep on performing uh, daily life activities, plus some extra exertional activities, and that may not affect them much. But as soon as starting from this age group onwards, definitely affecting elderlies much more quickly and much more severely. But starting from this age group, when a person becomes less and less active, right? For example, when you used to walk like 6, 7 kilometers in a day, and then you're now not walking that much. You used to, go up and down the stairs, quite many stairs every day, like 6, 7 stories, or maybe more than that. And now you don't. it definitely deconditions you for that kind of effect, right? So just like in case of China, when you were in China and you were going to your classes and for labs and whatnot, right? You had to go up and down to your classes a lot, running up, coming down, and they were quite high. So you were, and then you had to walk to the classes, and most of you, and that was quite a lot of effort going up to your dormitories. So many stories up and down, and quite a lot of kilometers, at least I would say 6 7 kilometers a day for everyone. And compared to that, now most of us may not be doing that. We are deconditioned now, simple as it is, right? So for elderlies, when they become mobile, this deconditioning happens much more quickly. What's that? It's basically adaptation, right? These are adaptation changes that happen in response to decreased workload, right? So cardiovascular deconditioning means that the heart, while being immobile, when a patient is totally immobile, recognizes in these age groups much more quicker that, you know, it does not need to work as much and as hard as it used to, because the requirement, the need for all that output containing oxygen and nutrients is not there in the muscles as it used to be. So it does not need to, you know, work as much or as hard as it was. So you'll see overall what cardiovascular deconditioning means. It entails alteration of heart rate, it entails decreasing cardiac output, it entails therefore, cardiac output and beating of the heart altogether dictates the pressure, hydrostatic pressure, and obviously the hydration status. And therefore, immobility, especially leading on to not using much of the limbs muscles. Remember, muscles of the calf specifically are known to be extremely important. They play their role in pumping basically around the vessels in the limbs and help the return of the blood back to the heart. That's not also working, right? So the hydrostatic pressures in arteries as well as veins, but more importantly veins, also change, decrease, and then that would affect the movement of fluid between the vessels and the surrounding intra interstitial tissues. So fluid shifts become, I would say, inefficient, or the fluid starts to become more pooling within the tissues, and therefore edemas become quite common, especially in limbs of elderlies. So decrease cardiac output because the muscles don't need them as much now, as much blood and nutrients and oxygen, because there's no, and decrease peak oxygen uptake also takes place. Breathing rates, respiratory rates may also uh, be lower than before. So all of that happens within a few days. Heart rate, for example, if you've heard, athletes can be running for hours, or what you call it, Tour de France, bicycle races, right? It requires a lot of physical exertion, but these athletes have conditioned themselves so much that they breathe less, and their heart beats less as well, and they're still capable of performing at peak. So that's called conditioning for their physiological activities. So when there's no activity at all taking place, uh, heart rate, which obviously is going to be uh, adjusted for the cardiac output. When the cardiac output requires to be reduced, then uh, heart rate also. Initially, you may say it would decrease, but the point is, uh, just as in case of athletes, I gave an example that their heart rates are slower, much slower than you, because their hearts or muscles are strong enough to do the required job with less beating. Right? That's what it is. And so they are slower. But then in these elderlies, workload decreases, cardiac output decreases, and the muscles become weaker. So not only it's the skeletal muscles, but it is basically the heart muscles too. So the weaker muscles then need to work more. And the rate also therefore increases to compensate with that weakness of strength and capability to pump out blood. So a resting state heart rate, which is supposed to be within the normal ranges, right, increases as well. And so another important, easily identifiable change in the heart. Next, we have postural hypertension stemming out of all these changes. I hope you remember what was postural hypertension, right? Can you guys recall it? Postural hypertension. What was the definition? Yeah, it was a certain degree of decrease in blood pressure within sometimes 10 minutes, uh, depending on the type of postural hypertension. So within a certain period of time after sitting up from a lying down position or a standing up from a sitting down position, uh, you know, change in decrease in BP, and the change could actually be more than 10 to 20 mmHg. So, and that's different obviously for systolic and diastolic. So, but you get the point, and you can recall it. Postural hypertension, right? So that also starts to become a thing in elderlies, and it's this finding is the most common, postural hypertension. And remember, we youngs as well, especially when start to get this could be a sign of many other things, specifically deconditioning, right? So if youngsters start to feel it, could be a way, and that's one of the major things that among all of these things, this heart rate and postural hypertension are the two things which could be quite be present in youngsters as well, or young ages too. Right. So, what are the hazards of bed rest in this age group? Atrophy of skeletal muscles. Right. So, skeletal muscle mass would be decreasing, weakening therefore of overall the patient, and decreasing body weight as well, and obviously loss of strength along with the atrophic muscles. Right. So, pressure injuries used to be called as pressure ulcers or bed sores. So they're not called as ulcers anymore, because when we study this topic separately, you'll see that it is categorized. There's a way to categorize them, because based on those categories we need to decide how to treat them. Right, the best modes of addressing different varieties of pressure injuries or sores, better called that way, instead of ulcers, because not all of those are going to be ulcers. And if you go back to the definition of ulcers, how are ulcers defined in pathology? just excavation, right? You had to remember this one word, excavation of the tissue, starting from epithelium, and then depending on its depth, exactly a chunk of tissue is so the bed sores or pressure injuries, not all of them are ulcers, right? So they may involve different degree of layers of tissue, right? They may only be affecting epidermis or just dermis or much deeper as well at times. And for that reason, they're not always called as ulcers. So the name has actually been changed now. So if anyone around you starts to call these injuries and sores as ulcers, tell them, categorizing them, lead on to this outcome of not calling them, because you'll see in that categorization of different, it advises us basically, the deeper the tissue lost, the more the tissues involved, the changes, inflammatory changes, and then wetness of the sores, and healing and repair requirements, needs, and time required to do all that would be different. So for that reason, variety of different types of bandages and otherwise approaches are used. There's so many different types of bandages used in treating wounds, especially when it comes to old chronic non-healing ulcers and burn injuries. So depending on which category they will be in, different varieties will be used. Now, anyone who has been immobile, remember I said some of them could also move, and but for maybe they were prescribed bed rest, had a fracture or whatever, leading on to be immobile, right? So they can move. Some of them can move. So when they can, and then they could become now weaker, right? So they could actually be at higher risk of having a fall. And fall itself is a topic coming up, and falling down for an elderly is a big risk on its own, on the very first fall as well as for the upcoming time and falls that they may have after that. So recovering from all that for an elderly could take weeks to months. How can we prevent it? First of all, for patients who can move, are not paralyzed, right, but are just maybe advised bed rest, and otherwise a week for them, promote physical activity, right? And now this recommendation ideally is for patients who are hospitalized, cause in hospital environment, an elderly who is hospitalized will pretty much mostly all the time be lying down because they have a bed, right? So, or at most you may see them on their bed with the back inclined. That's also better, right? But if they could be sitting up within their bed, because the back of the bed can be quite, tilted upwards, so that's even better. Or they could be sitting on a chair or a wheelchair by the side of the bed, right? But because there's a bed dedicated for the patient, so they end up lying all the time. And for them, require this recommendation is to at least have a walk, 5 minutes walk. Start with a short stroll, and then increase it to at least 10 minutes walk every time, right? However slow it may be, let it be there, but 2 to 3 times a day at least. Now, this is the same advice that I would give to any elderly in this age group, even if they're not hospitalized, right? Some people have small houses, others have, big houses, and believe me, this small and big house difference is a lot of difference. Why? You know, a big house, such as what we have a measurement of, let's say in Pakistan, canal or two canals, which has in terms of marlas, square yards, I'm not very sure about it, could be, you know, it could be like 4,000 square feet, or a bit more than that as well in terms of a canal house. So the bigger the house, the bigger the rooms, the further they are from each other, And for everyday activity, drinking water, getting something out of a fridge as well, you can't imagine it how much more we have to walk, right? It's literally the difference that if you're living in a small house where everything is very close to you, you'll be walking, in my opinion, not more than 6 to 700 steps a day. If if daily, like, within house activities are the only things that you're doing, right? Not going out. Compared to if you're living in a big house and then you're not going out of the house and just doing daily uh, activities within the house, getting stuff from kitchen all the time and going to the lounge, sitting in the room, to the toilet, maybe upstairs, right? Stuff like that. In a bigger house, it would be at least, in my opinion, in my experience as well, 4 to 5 thousand steps a day. Now, what's the difference? Look at that, 10 times the difference. Activity that a person living in a small house compared to a person living in a big house would be doing. So that is something to be accounted for in terms of elderly, especially, right? If they're mobile, but if they're living in a small house or a big house, and then if the daily activity does not include any extra activity, this matters a lot. So advise them to, on top of their everyday chores and activities within the house, advise them to walk at least 2 to 3 times specifically for walking. Yeah, dedicate that time. And if it's too much to walk for heart failure patients, for example, just walking for a, how many, let's say 15, 20, 30 meters can also be tiring and makes them out of breath. So advise, starting with, obviously, let's say just walking 10 meters, then 15 meters, and then increasing it slowly and steadily. But walking is crucial to keep them in as much conditioned way as possible. So these are a very important things to keep in mind: the sizes of the house and importance of the walk. Sitting upright for much of the day will minimize the worst of the outcomes of immobility, but then again, just sitting will also not be the best case scenario. Now, let's say a patient just have to be immobile. There's no other way around. They are paralyzed and they can't move, and that's it. So in that case, if nothing else, at least physiotherapy to avoid the contractures to be developing, especially at joint areas. And you know what contractures are, right? Excessive uh, fibrous tissue deposition leading on to excessive shrinkage and pulling of the tissue together. When it develops over the joint areas, it restricts its movement. So, knee joint and elbow joint, fingers, all that, right? So, for patients who just don't have an option, who are paralyzed and they have to be on the bed and there's no other way around it, for them, physiotherapy is extremely crucial to prevent development of these contractures. And number two, remember, when passive movement of limbs and all that is going to be done, chances are, that the resistance that the muscles offer basically to the movement when a tone is being maintained in the muscles, that resistance itself can lead on to, exercise benefits, because to create and keep that resistance in the muscles, that also is some sort of energy and force and effort being exerted. So extremely important physiotherapy. Now that can be done, basically these are basic physical exercises, can be carried out by anyone at the house as well, but learn them. And what, because there's range of motion, and there are different directions of rotations as well that would help the patient keep them in shape as well. So range and strengthening exercises are important, right? Start immediately as soon as the patient is immobile. right? When there is no other way for them to actually be keeping themselves mobile, and keep these physiotherapeutic range and strength improving exercises ongoing as long as the patient will be immobile. Now, on top of that, now imagine a patient who is not fully immobile but can move about and is in a hospital and is on the bed, right? And they want to move about, but they have IV lines, catheters, IV cannulas. That's not much of a big thing. Uh, Intravenous catheters, indwelling ones, because once an IV cannula, sorry, is put in, it's left there for at least a few days, as long as it can be used. I would say 3 4 days a week is not a bad idea, as long as it keeps and remains functional and it is flushed timely ways, and it does not get blood clotted in it and does not get blocked. So keeping that in mind, IV lines as an IV cannula remaining may not be. Yes, they are a cosmetic thing, and a patient with IV cannula, wherever they go, uh, the person who sees it knows that the patient is on some treatment. You may think that it's not a big deal, but believe me, it is a big deal. Some people who are being treated for stuff, elderlies or not elderlies, people coming from the place of strength, don't like to be seen in the times of their, seen by everyone or seen by public, let's say, when they are in the moments or state of weakness, right? So they don't share such moments with everyone. And if, let's say, they have to move about and they have to go out and they have to be in the office, let's say, or let's say they have to go out from their room and be in a gathering with an IV cannula on their arm or a hand somewhere, can give it away, and that is a problem. So they may not move as much with an IV cannula or IV line as much as the other. So this does not apply to everyone. A patient already in hospital, living there, staying there, and IV cannula, I don't think would be much of a problem, right? So different scenarios, but avoiding IV lines can improve mobility, right? Restraints, obviously, avoiding restraints can lead on to improve mobility. If the patient is restrained, they won't move much. Urinary catheters, extremely important ones. We've talked about them previously as well. Indwelling urinary catheters, which, if put in a hospitalized patient, will be indwelling, will be left there. So the patient does not have to go to the toilet to urinate. All right. Now, if avoiding urinary catheter is a possibility, avoid it in elderlies. Because if you put it in, they won't even walk that much. They won't even go to the toilet for urination. Defecation would be like once a day or twice, once in 2 days, right? But for urination, the patient does have to go to the toilet quite a many times a day, and then when they are getting IV fluids, even more number of times they'll have to go to, so that keeps them much more mobile. So avoiding urinary catheters as much as possible as well, but sometimes we just cannot avoid them. We just need the catheters and the urinary bags for example, measurement of the urine output. Are you guys there? Yeah, what's the time? Time almost for the break. Well, let's just get done with this slide. Right, so uh, trying and preferring not to have these will improve the chances of patients being mobile. Or another thing, if they are immobile, for them to become mobile, as soon as they can after recovery from their illness, right? So they, for example, a patient may be in a hospital for a surgery, right? So the longer you keep the urinary catheters in, the longer you, if you know it was psychiatric patient, keep the restraints on, the more longer you keep the IV lines in, the more delayed the person's mobility will be, right? So that's another aspect of looking at it. Pre and post discharge advice, therefore, should be given by the physiotherapists, ideally, for this age group. What advice is going to be is for going to be for exercises, right? Different varieties of exercise, and they're very simple, going to be, range of motions for the legs, at knees basically, and at hips, and for arms obviously, elbows and hands too, and how many times a day they should be walking. And otherwise, if a patient basically will be going back home with problems such as paralysis and whatnot, immobility, then even in that case, what variety of exercises to keep on doing. And you'll see a lot of more exercises to be talked about. um, some even have their names. Next topic is falls and gait disorders, and that we'll talk about after the break. Let's have a break here, 10 minutes, and then start the new one. All right, guys, I'm back. Please confirm if you're able to hear me loud enough and clearly. Okay. Now, coming down to falls and otherwise gait disorders. Fall itself, as I've been saying, is a major problem in this age group and is associated with multiple types of complications coexisting prior other conditions and very much worsening the life expectancy as well of the patients in this group. So extremely crucial, right? So this figure, one third of 65 years age fall each year. One third means 33% roughly fall each year, and therefore whatever we'll talk about later on means 33% of 65 years of age and above are going to have likely those worst outcomes and the complications associated and other problems, and like will more likely be dying within a year or so. That's a huge number, right? And overall, within now that number of patients who would fall down, 10% of the falls will lead on to serious injuries and worse outcomes. What usually are the things that happen? Most commonly, I would say it's fractures, and within the fractures, it is the wrist fractures, hip fracture to be among the most important ones, or otherwise any other bone fracture. Remember the other day I was with a friend of mine. He is an orthopedic surgeon, and he had to, he was called to the hospital um, when he was not supposed to be there because he had a patient, a child, who was sleeping on the bed and then just rolled off the bed and fell down and broke his arm. Such a minor fall can also lead on to a fracture. So that was a child, and elderlies, the same problem. Malnourishment, and especially if weakened bones is a problem, right? So even a minor fall and yeah, points of impact can lead on to fractures as well. So soft tissue injuries are also a possibility. Worst of worst, if an elderly falls down and hit their head very bad, obviously then internal head injuries and brain injuries can also be hemorrhages as well, right? Hematomas and their effects therefore. So as I said, in this age group, complications that arise from fall are the leading cause of the death. Hip fractures, the most common, among the fractures, these are the most common fractures. And when hip fractures take place, they are the most important ones for then permanently disabling the patients, for placement of these patients into a hospital or a care home on permanent basis, which means a fall with a hip fracture can change a person's life forever, right? So varying degrees of functional impairment, nursing home placements, even death, right? Because these fractures are one thing, they're fractures, but they're injuries, non-healing ones later on can further. You would have studied basically blood loss obviously, as well as uh, internal injuries, hemorrhages, um soft tissue injuries by the sharp edges of the bones, and chances of basically infections as well, and then furthermore problems. If improperly handled, can lead on to not properly aligned joinings of the bones as well, and that in itself can be another problem. Weakened joinings and further possibilities of fractures, even with lesser form of let's say impacts. Right. So don't forget to ask the patient about falls if they've ever had one, even if there was no injury at all. Right. Even if there was no fracture at all, even if there was no problem at all, even a soft tissue injury was not there. Ask if such an aged person has had a fall, right, or a near fall scenario, or do they have, or do they get bumps here and there all the time while walking and whatnot. So ask about it. Once you get the information, you've just seen the statistics, and that is extremely important. Assessment should also therefore include the patient's postural BP, which means check for postural hypotension, check the patient's pulse, and examine the patient's cardiovascular system, and obviously not just postural BP, the normal BP as well while lying down too. And obviously, here in this case, if you're now focusing on the cardiovascular system, ask about the drugs that the patient is on, especially for control of hypertension, because hypertension is extremely common too, because it could be the drugs maybe. So when you are inquiring about stuff, do not forget about these things. Strength and range of motion evaluation for patient as well, to see if they have any weakness, any limitation to the range of movements, which could have basically altered their capacity to move around and make alterations and changes to their posture uh, and gait. Right, so assessment for strength and range of motion evaluation. Assessment also required for cognition and proprioception evaluation, and you know what these are for. Um, Maintaining balance and being able to basically plan for the motor activities, being able to have the corrective adjustment movements against uh, the movements that are initiated in the first place. All those things are extremely important. So cognition and proprioception are crucial for those corrective movements and precise motor activities. So assess the patient for cognition and proprioception as well. Examination of feet is extremely important. Now, why is that the case? Now, examination of feet is, I would say, crucial not only in terms of elderlies, but also with any patient who comes to you with a job or with daily activities or profession requiring them to walk and stand a lot. And it's not necessary; it's just you know uh, low level jobs, let's say, right? Even the white collar jobs of sorts require a lot of standing, a lot of walking. For example, teaching, for example, being a civil or any other variety of most varieties of engineers who visit sites and walk and survey stuff, lands, right? Um, and then obviously athletes and sportsmen too. A general person, I mean, who has, for example, a flat foot is very much prone basically to uh, pain in the foot, altered gait, and the problems rising from that too. I have a relative who is 27, flat foot, and he has pain in his one foot specifically for the past 7 years, and the pain is actually quite a lot, disabling. So much so that he's been seeing so many. podiatrists, orthopedic surgeons, and physiotherapists. And so whenever he plays just table tennis as well, imagine table tennis. He plays table tennis a lot, so he plays table tennis when he has a couple of days of the game. After that, it becomes unbearable. So he is flat foot. So that's that's just the local pain so far. But if being excessively flat foot is not addressed, it is affecting the posture, the gait of the patient, and with the long life ahead, that can lead on to basically affecting the spine as well. And then more problems stemming out of it. If you ever watched any physiotherapy videos, tell me, has anyone ever watched physiotherapy videos online on YouTube by chance? No. So there's very few, or quite some, let's say, not very few, quite some extremely famous physiotherapists, who YouTubers, uh, from US, from Thailand, from Singapore, mostly from US, although. And yeah, I mean, they do wonders. Believe me, they study physiology and anatomy, especially anatomy. And why I wanted to mention them here is that, um, the videos that you see, one of the tests or some examinations that they very commonly do is they ask the patient to lie down on the bed, whatever the bed they have. They have this special uh, lying down and sitting up equipments or seatings, let's say. So they lie down the patient flat on the bed, and look at the feet alignment of the patient. A lot of the patients that they see have one leg shorter than the other. So a foot would be much lower than the other foot, right? So, and in that case, it does not mean that they have a shorter leg. What they tend to have, if they're seeing obviously a physiotherapist, what they have is basically a misaligned spine. And that ultimately over here leads on to, one leg becoming shorter and one uh, longer than the other one, appears to be that way. And this significantly affect their gait as well. And then the pains that arise from that, extraordinary. And therefore basically, they then have quite a few other variety of tests as well, and that they run them and then identify the point of problems, misalignments, and then release the pressures from there. And then, miraculously, within few sessions, I won't say one because you can literally see the difference within one session as well. But within few sessions, the difference is magical, and the pain simply vanishes away. Obviously, not every type of problem can be addressed by the physiotherapist, but I'm saying how crucial and important it is to look at one's gait and feet, and know that what variety of problems can stem out of it. Crucial, excruciating, disabling problems, which can be fixed without massive, interventions, um, like surgeries, for example. Without that as well, physiotherapy. So orthopedic interventions and physiotherapy goes extremely hand in hand. So examination of feet with a simple test that we call as a wet foot test. I have downloaded it here. Wet foot test example. So it's a text basically. So what you do, you basically can do it yourself as well. Get some water in a pan, not too much, just a little bit. That when you put your foot in it, the pan, I mean, not all your foot is drowned in it, just the bottom of your foot gets wet, right? And it should be low enough that, that your curve that you basically have, the arch of your foot if you're not flat foot, does not get wet, right? So it should be that much little. So thin layer of water, right? And then put your foot into it. Flat. So your flat sole will be wetted, and then paper bag or any paper basically, right? And then step on it with that foot. So, and look at the imprint that that wet area creates. Better if the paper is dark color paper. So you see three main categories of feet. This is a normal foot with the arched area of the foot, right? This is where the foot is raised. And when this arch area is as much, right, then the posture of the legs and the spine are not affected. But if imagine somebody's flat foot, this arch or high arch, even much more than that. So in this case of a patient, that there will be a deviation of the foot outwards, right? And in this case, the deviation of the foot and therefore the leg and the hip attachment basically will be all aligned inwards, right? So that will alter the way the person walks, the way they can run, how fast they can run as well, and the future possible problems that may arise because of this and the degree of their physical activity, right? So such a person if they're flat foot means that, I mean, in this age group they would already be having a lot of pain in their foot, they would already be having possibly pain in their back as well, and that would have led on to them be less mobile as well. So they need stability shoes, and these either these are handmade shoes specially for such a person, obviously after analyzing their foot, or their insoles these days that you can simply buy, orthopedic insoles for flat feet. So you just slide them in your existing shoe, provided if it is loose enough to accommodate for it. Some shoes are very tight. And then, this person's foot becomes not flat foot. And therefore, the effect of disalignment on their limbs, on their hip, on their spine simply start to fade away. So it affects a lot. It affects a lot, believe me. I don't. I've not literally checked my feet all the time. I don't think I'm literally this much flat foot, but I'm not as arched as this as well. And I've, had worst pains after standing for so many time in the classes during lectures. So you remember I used to walk all the time pretty much because standing, is much more of a problem than walking. So this is a flat, the wet foot test. Simple as it is, but can be done by anyone at their home. And otherwise, we have this up and go test as well. Another one, up and go, right? So in this one, we basically um, ask the patient to sit down on a chair and then find a line which is supposed to be 3 meters, or specify a location 3 meters away from them, right in front of them. Has to be 3 meter or 10 feet. And what you need to ask the patient is when you say go and you time. So this is also called as timed up and go, right? Because you are going to time them. So you say go and start the time, and you have already told them that they need to get up, walk normally as they walk to that location, and come back, which means then getting to that point, turn, walk backwards, and come and sit on the chair again. So the time required for this is, if let's say more than 12 seconds, it's basically an interpretation to having disability of any sort that is affecting their gait or their ability to walk normally enough, right? And they cannot return back to their position within uh, 12 seconds, right? So most people are able to do it in less than 10 seconds, I would say. 10 feet is nothing at all. 10, or one step that a person takes is a little less than a meter, and a meter would have more than a couple of feet in it. So this 10 feet distance going and coming and turning and getting up and sitting down does not ideally take more than 10 seconds. So more than 12 is a very strong indication, right? So that's timed up and go test that is done for the elderlies for gait assessment or otherwise capacity to uh, move, walk. Problem could be with the gait, or problem could be with any other things affecting on the capacity to walk and stand. Right, so look at the footwear as well, because it could be, there's a lot of people who don't change their shoes a lot, and then they could be having quite a lot of heel in it, and then those heels also could be getting unevenly uh, consumed. So when that is the case, it's the shoe which is affecting basically the placement of the feet, and therefore the possibly effect on the gait as well. For elderly especially, a lot of them don't have much money, so buying a lot of shoes is not the thing that they do. So extremely important. Seems not much of a thing, but it is. And then there you go. Variety of different gait abnormalities with the possible causes underlying. Inability to stand without use of hands, right? Which means not using hand support to get off from a chair or from a sitting down position on a bed or from wherever. Now, from the ground, obviously, a lot of us, most of us, pretty much everyone uses hand support. So remember that. It's from sitting position or, um you know, from lying down otherwise, from a bed, because getting up from a bed is different from getting up from the ground, because you can lower your legs from the bed. So deconditioning is the most common cause. Myopathy because of variety of things, alcohol, statin induced hyperthyroidism. Hip or knee pain can also be responsible to keep the person from standing without the use of hands. Unsteadiness upon standing could be because of ortho, which means the patient is standing but difficulty maintaining the balance. Orthostatic hypertension, balance problems, peripheral neuropathy, vision problem, vestibular, right, central nervous systems, variety of other issues, generalized weakness. All of these could be the reason for unsteady stature while standing up. Stagger with eyes closed. So when you ask the patient, when the patient is standing and you ask the patient to close their eyes, and then that leads on to them becoming unsteady, right? So it may indicate that the vision is compensating for another deficit in this case. So it could be a sensory loss of another type other than the vision. Short steps, if when the patient walks, is taking smart, it's not usually as long a step as I just mentioned, to be like a bit less than a meter, but much shorter. Weakness or Parkinson's disease, remember, steppage gait. Asymmetry of gait could be because of cerebrovascular accident, facial focal pain, or arthritis, right? Pain at a certain point within the limbs or the back, and arthritis, we know. So or it could be because of weakness caused by cerebrovascular accident, not paralysis but weakness. Wide based gait represents balance problems mainly and fear of falling down, basically. Flex knees could be because of just weakness, right? Quadricep weakness or contractures. In case of, we've seen them a lot of the times. Slow gait could be because of, then again, many reasons: deconditioning, weakness, fear of falling, peripheral vascular disease, chronic obstructive pulmonary disease, COPD, heart failure keeps them from walking normally or fast, right? Get out of breath very easily, angina pectoris. These are the conditions which are leading on to slow gait of a person. And if they walk fast, they can, but if they do, running out of breath, mostly associated with pulmonary or cardiac problems, right? But if running out of breath is not there with the slow gait, then it could be because of peripheral vascular diseases, weakness, and fear of falling majorly. Clear? Are you guys there? So I'd recommend you guys to look for uh, physiotherapist videos on YouTube. Amazing. Right, up and go test. We have already talked about it. Completed within 10 seconds, normal greater than 13.5, it's mentioned here, but in the one that I've downloaded, it mentions 12.5. Now, this 13.5 is from the current medical and diagnosis. I think I would have not wrongly got it. So I'll check it again, because in that test actually which I've downloaded online, that says 12.5. Anyways, the causes of fall can be the balance problems, and that could be because of cognitive, neuromuscular, cardiovascular function decline or affection, right? It could be because of aging, because aging simply, does a lot of things. It does lead on to slowing down of physiological process, metabolism, and what it leads on to reduce reaction times as well. So the corrective movements that are happening all the time in our bodies, against the motor activities initiated or just to keep balance, those may be delayed as well. So as a result of that, in aged individuals, swaying in Urdu or Hindi that we call as jhulna, there is a factor of swaying that prevails, right? So the more the frail the patient, the more deconditioned the patient, the more the sway in their gait may be, right? And that can also increase the risk of the fall. Prolongs response time, balance mechanism is compromised because of dependency of balance on so many different things that you already know, different sensory inputs and whatnot. Postural sway is also increased. Additional insult to any of these systems and or additional changes can lead on to keep on increasing the risk of fall for such a patient. And you know what fall can do. Causes of fall are variety. Continuing from the last slide, medications can also, especially the one for hypertension and the ones for depression, the ones for mood alterations, right? Sedatives, hypnotics, antidepressant, benzodiazepines. Most importantly, benzodiazepines have been seen to be the cause for the fall, right? And other variety of problems from within the body of the patient or internally. Sensory input, uh, for example, glasses with multifocal lenses. What is a multifocal lens? Any idea? Maybe I've mentioned it a few times before. What is a multifocal lens? Anyone? Bifocal, yeah. So it's a single lens for people who are nearsighted as well as far sighted. It's for those people. So one lens basically is with the capacity of near and far sightedness. So most of the lens is for for far sightedness, but because while reading newspaper and books, for example, you're looking downwards, so the lower part of such glasses is for nearsightedness, right? And if obviously such glasses are being worn by the patients all the time, right, while going out and about and walking too, that is a problem. Then it can lead on to impaired balance as well. Yeah. So that is usually just for sitting and reading and then being able to look up and around and still have the vision, not for wearing and walking all the time. Right. So multifocal lenses and urinary urgency. How do you think urinary urgency can lead on to fall? Anyone? Yeah, urinary urgency is associated with quite a few things in this age group. Rushing to a toilet, exactly, with limited capacity to actually have motion, right, can actually lead on to increase the chances of fall as well. Judgment, cognitive impairment, right, can lead on to increase the risk of fall. Blood pressure regulation, postural and postprandial hypotension. Postural, we have already mentioned. Postprandial, after meals, there's a, and that also is associated a lot with postural hypertension. So these two varieties of blood pressure, which means altered nervous system's capacity to regulate the blood pressure. Reaction time. Now we have already mentioned aging leads on to uh, increase reaction times, right? But altered sleep, which means exhausted individuals, patients suffering from insomnia, can't sleep at night. Definitely, I mean, sleep deprivation has its own effects, right, on the individuals. So their response and reaction times are going to be even more affected than a normal elderly, or otherwise, the same kind of sick or affected elderly as them, but they are now even sleep deprived. So insomnia, if so, you see, treating somebody insomnia or helping them improve having good sleep has so much far-fetched effects in this age group. If you don't address their sleep very well, they can actually have a decreased reaction time, which can lead on to the risk of falling, which can lead on to them dying within the next year or so. Imagine that. Balance and gait, because of are being altered because of dizziness. Now whatever may be causing it, a lot of things can cause that. Impossible to isolate and remove all causes, uh, obviously is a fact, but you keep on evaluating the patient, identify as many as you can, and alter and modify as many as you can, improving the chances of the patient not to fall, right? That's what we can do. So once a patient falls, what happens? Fractures, most commonly wrist, hip, vertebrae, among them most importantly hip. And here you see the women, 20% of elderly women with hip fractures die within a year, right? So that's not a good statistics, dying within a year after falling. Chronic subdural hematoma and its outcomes, right, with the neurological effects. And now there's another variety of a problem with the falls. There's one thing that, okay, risk factors with the fall, the causes for the fall, when the patient may fall, what are the possible complications. And then there's another thing: if a patient falls down and cannot get up, now If a patient falls down and has hurt themselves and cannot get up, that's another thing, right? If a patient falls down and for whatever reason cannot get up, its consequences possibly for the patient in different scenarios. And a patient cannot fall, they fell down, they hurt themselves, but they're not as hurt as they, you know, that it is impairing them to get up. But uh, being unable to get up because they're frail, right? So there's actually getting up from a fall guidelines for elderlies. So training for getting up after a fall is also done for elderlies, and there's a way. So what is the way for an elderly to get up when they, if and when they may fall down? Number one, uh, well, if they've hurt themselves very badly, and if they can call for help, then call for help, right? And don't move. Secondly, if they can, uh, they think that they are not injured seriously and can move, and especially in a case when there's nobody nearby, then they need to get up, right? Then they cannot remain where they are, because it could be many different scenarios. It could be very hard weather, it could be uh, warm, hot weather, it could be cold weather, it could be freezing, it could be outside, it could be inside, right? Different scenarios. So if they can move, and there's no one else to help, then a patient should first, let's say they've fallen down and now they're on their back, so they should, whichever side they choose to now lean towards, first move the hands towards that side. Take the arms and move them to the side to which they want to roll to. Number one, roll towards that. Let's say it's the left side, so move both hands and arms to the left of their body, put them on the ground, and take support and roll towards the left, right? And then during this maneuver, all the time, patients can stop and you know take breathe breaths and take as long as required. It could take many minutes as well. Weak and frail and elderly, multiple problems. So time does not matter, but they should make sure that they are resting in between as well. So turn to the left, let's say, and afterwards uh, get into the crawling position, right? Which means they are on their knees, hands on the ground, knees on the ground as well, right? So in this position, they can start moving towards a nearby chair, and then when on a chair, they would put first one hand and then both hands on the seat of the chair. Then one leg should be bent in a position that their foot is now on the ground and knee is bending. The other other leg's knee is still on the ground, right? So like in a proposing position, right? So the knees are like that, both legs like that, one knee down and one foot on the ground with the knee bent. And then from there, obviously, they take the support of the chair and then turn and sit on the chair, right? So this actually is a training that is given to elderlies basically in old age homes as well, and especially to people who are at risk of fall. And how do you assess that? You already know that, right? So if the patients in different scenarios fall and do not get up, are unable to get up, it can lead on to dehydration, electrolyte imbalance, pressure injuries, rhabdomyolysis, hypothermia. As I said, in different scenarios, could be different places, outside, inside, cold, warm, could be different things, right? and how bad they've fallen, how bad not. Fear of falling again after a fall is extremely common in individuals. That's why, I mean, they may stop walking as well. They may stop being mobile. That's another problem. Needs addressing, isn't it? And therefore, the physical therapists, gait training, and then physical therapists, this getting up after a fall training are important for the patient to regain confidence and therefore not be immobile. Are you guys there? Now, take a look here. What's the time? Take a look here. Um, Fall. This is obviously prevention and management of fall now. Risk factors for fall and targeted interventions for them. Now, on the left, you have obviously the top of this table is different. Exercise or physical therapy, varieties that you have: Tai Chi, gait training, balance training, strength training. Tai Chi, is not only practiced, it's shadow boxing, otherwise called as Tai Chi. It's not only practiced in China by elderly, especially. Now it's even, practiced and played otherwise, let's say, in West, even US. Other way, I was watching a movie called as Internship on Netflix. An old guy after retirement, becomes bored and start to do internship. In that one of the scenes, he was also doing Tai Chi in Central Park, New York City. Yeah. So, what's the beautiful thing about it? The position and the movements basically are the most important thing in the Tai Chi. Half bent knees in a certain way for both legs, maintaining the balance, and slow body movements, right? That leads on to resistance and strength training, especially core strength, which is extremely important for back support as well. We people who start getting a bit older start putting on a bit weight, like me, around the belly, right? For us, the core starts to become weak when the weight start to be gained. When the core becomes weak, for example, and the weight start to increase, all the burden that basically goes to while standing up and bending and straightening up the back is directly going to the spine, not even muscles, spine alignment itself. Instead, it should have went to the muscles around the belly on the back. So when the core is weak, that straight away goes all that pressure and effort to basically get up is transferred to the back muscles only, and that affects the spine as well. So very 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 common to be happening, as they say, chok nikal jana, right? That happens because of this weak core mainly, but other reasons as well, but this is very common. So and otherwise, multifactorial interventions that are going to be pick and choose: home safety assessment, medication review or specific conditions, advice on appropriate footwear, vision check, adaptive aids as appropriate, physical therapy, or exercise as appropriate. These are a variety of things which are going to be picked and chosen for different. Postural hypertension, right, greater than 20 mmHg drop in systolic, or systolic blood pressure greater than less than 90 mmHg. If that is the case, targeted interventions, behavioral recommendations such as hand clenching, remember postural hypertension kind of stuff, elevation of head of bed, discontinuation of substitution of high risk medications, which are basically antihypertensive in excessive dosages. Use of benzodiazepines or sedatives, if that is the problem identified. Education about sleep hygiene, discontinuation or substitution. Having a bath before sleeping, um, um, and making sure that the patient has urinated and, if required, already defecated before sleep will improve the sleep, right? So may not even need to actually get up many times at night. And therefore, when to stop eating and drinking before sleep as well is a kind of advice. Don't eat and drink just like half an hour to an hour before sleep, and um, you know take a shower a couple of hours before sleep as well. So if you do all that kind of thing, it improves the chances of having good sleep. So if you have good sleep, you don't need these drugs, and if you don't need them, obviously the chances of fall then also decrease. Discontinuation or substitution of medication. Use of multiple prescription medications. Obviously, we'll have a whole topic on this, and there's beautiful recommendation. A document is called as stop and start document, or a tool which helps us assess which medications to give and which not to give together if they are interacting with each other and causing some adverse effects, for example, right? Otherwise, when a patient elderly comes to you, we're always supposed to do a review of their medications. That is going to be advised in case of if multiple drugs are being used by the patient. um, Environmental hazards, like if the patient lives in the house, and in the toilet, for example, they don't have supporting rails to get up and sit down on the toilet seat. On which toilet seat? On the English commodes, as we call them, not the Indian variety of commodes. Even if they're Indian variety of commode which the patient like to use, even more necessary for the support rails to be there. What are those? They just, like the railing on the side of the stairs, something to put a hand on. So it's basically a pipe fixed at angles on the wall beside the uh, commodes, right? And that's what we call as support rails for patient to hold on to while sitting down and getting up. So environmental hazard assessment means basically those are not to be present, or wherever the patient usually sits and eats and lies down, the support mechanisms should be placed, right? Grab bars, for example. Gait impairment, for that, obviously, gait training, assistive devices, balance and strengthening exercises can be recommended. Impairment in transfer or balance, then again, balance exercises, training in transfers, just like training in getting up after fall is required. Environmental alterations, getting those support rails, grab bars, for example, to be in place. Impairment in leg and arm muscle strength and limb range motion, exercise with resistance, bands or putty. Putty is kind of, uh, imagine, what, play-dohs, for example. If you know what a play-doh is, a plasticine, a soft yet hard kind of thing that you can squeeze and press and whatnot. So putty is something like that, but a bit, I would say, comparatively a bit more harder than that, right? So handling that, pressing it, molding it, squeezing it. Stress balls, if you see that, yeah, they are for stress as well, and then secondly made up of different materials. So that as well can lead on to strength gaining of the hands, more importantly, right? So putty training, the word stands for that. um, and then with gradual increases in resistance to the movement and the consistency of the putty. Vision impairment, obviously, do whatever is required to fix that. For example, cataract surgery, refraction errors, get the eyesight checked. Whatever is the problem, if it is fixable, fix it. High risk footwear, right? What is that? Uneven heels, high heels. Even if the sneakers and joggers are being worn by elderly, advise them not to be of very much thickness, the heels, I mean to say, because that is not something that, it's a risk that the elderly should not take, of having sneakers or joggers or shoes with higher, thicker soles or heels, as they called as. So um, all these are crucial advices and are definitely important for preventing falls. You've seen how many people fall each year, how many of them actually get um, complications and then personal impairments, permanent impairment, and therefore risk of death within a year. That's crucial. Right, minimum outweigh harm of the drugs. Uh, so if the drugs are, causing more adverse effects and harm to the patient than the benefit, that is a general rule always. We can definitely consider discontinuing, especially in case of Parkinsonism and orthostasis causing drugs. That includes alpha blockers, nitrates, antipsychotics. Now, screen one most important and first of the things that we might do in case of elderly, especially females, is to check them, screen them for osteoporosis. And how do we do that? Basically, bone scans, bone density scans, and they're called as uh, DEX-rays. Special type of uh, radiological imagery study, and ultrasound scans for calcaneus bone. So, all right, that's basically done to assess the density of the bone. And if density is less than usual, basically calcium supplement, vitamin D, which basically will help calcium, sources in the body, is done. But without any, this bone density decreasing, if vitamin D supplementation is given, it is been found to be associated with increasing the risk of fall. God knows what is the connection, but do not prescribe vitamin D without its deficiency or weakness in the bones, right? If you do, you may get, influence an opposite effect completely. Okay, let's just stop here. The topic is finished anyways. Thank you very much. Hope it was understandable. Then again, these topics are quite obvious, but there's so many aspects of them that need to be talked about and their importance need to be raised. And I'll see you next time in the class. Thank you very much. Take care. Bye bye.